So just to, I give you an overview of this session. I was a selector of the cases that were sent to the EBC committee, and by chance, all the best cases were dealing with the same complication. And two cases that we selected were a protrusion from ostial LED to left main, and the other two cases was protrusion, protrusion for the left circumflex to left main. So different complication, but the cause was the same. So I decided to give a title to this session, and nailing the ostium without and prevent to nailing the patient. So my last presentation, the first one, is just a summary how to prevent this complication, and during the cases we will see how to deal when the complication occur, and what you can solve the problem when it occurred. So it's time. Yeah, we can start with the first one, which is a presentation of a main bifurcation when all doors are closed. It's Himanshu Gupta, the presenter from India.
I just play from here. Hello, good afternoon, everyone. Welcome to EBC, and it's a big responsibility opening the batting for the meeting, and the opening case is always important, and I hope that it is educational as it was for us when we treated this young man. So the patient in question was a 43-year-old man with history of smoking who works as a rickshaw puller, just like a manual laborer, who underwent a PCI to LED 2 years ago at an outside hospital, records of which were not available when the patient presented to us. Presumably, the patient did well for 18 months following his first PCI, followed by which he had a non-STEMI. He went back to the same hospital where a POBA was done, and that was all we had in the records when he presented to us. His clinical presentation now was a non-STEMI with severe rest angina. His ejection fraction was 45% with some inferobasal hypokinesia, and he was having mild mitral regurgitation. So this was his angiogram. As you can see, the patient had a short left main, a very dominant circumflex, a stent in the LED, which we do not know whether it is starting from the ostium or in the left main, which is patent, and there is a very tight focal stenosis at the ostium of the circumflex. So you can notice it here that the circumflex is actually a very large vessel, and the right coronary artery was non-dominant. So it's probably likely jailed by the stent, but we do not know, because the records only said that the stent has been put to the ostium of the LED. The stent was patent. So we decided to treat this. We engaged the left main, we wired the LED and the circumflex, and at this point it is very important to do imaging to see whether your LED wire is intra-stent and where your circumflex wire has crossed, and what is the level where the stent is starting and ending. So this was the IVUS. We see the circumflex wire coming in from 3 o'clock. It is entering through the stent struts, so probably there is just one stent strut in front of the circumflex, as you can see here. And the LED wire is also intra-stent, and the circumflex wire has gone through the stent struts of the circumflex of the LED into the circumflex. So as Dr. Remo says, that the patient is probably nailed. So this is the scenario. We know it's probably a very easy situation to treat, that we just wire this. We know the wire is through the stent struts. We dilate the stent struts, and we go ahead. So on the left side, you can see we have a semi-compliant balloon coming in without any difficulty into the circumflex. So very easily, the balloon crosses very easily into the circumflex. We start dilating a balloon. It doesn't dilate at 8 atmospheres, a semi-compliant balloon. Okay, so we take a non-compliant balloon. It's a non-compliant 2.5, 15 mm balloon at 24 atmospheres, which does not dilate at the ostium of the circumflex through the stent struts. So there is no dilatation achieved at the ostium of the circumflex. So what do we do? So it's an undilatable lesion, doesn't look so calcified. So should we take a bigger balloon? Should we go at higher pressure? Or because the balloon went easily, should we actually now image the circumflex ostium to see what is the morphology at this ostium? So that is what we do. We put the IVUS catheter into the circumflex, which goes very easily. And this is the IVUS from the circumflex. It's a large 3.54 mm vessel, some negative remodeling at this site. And when it enters the circumflex into the left main, there is no calcium at all. So there is no calcium in the circumflex. The vessel is 3.5 mm. However, the balloon is not opening. So we know it's a big vessel, so we can go more aggressive on the balloon. So we go in more aggressive. So maybe the struts are not opening. So we take a 2.75 12 mm balloon at 28 atmospheres. Still the stent struts do not open. We keep on dilating at 28 atmospheres, go up to 30 atmospheres, but the circumflex ostium is still not yielding at all. So at this time, we are left with very few options, as we see no calcification in the circumflex ostium, that what is happening. And this is the angiogram after very high pressure dilatation. There is no dilatation achieved at all at the ostium or the circumflex just before the high OM. So after this, we image again from the LED to see what is happening. So this is the image again from the LED. We see the circumflex wire coming in. We do not have any modification of the stent struts at all, even despite using 2.75 high pressure balloon. So we don't know what is happening. The stent struts in front of the circumflex look quite odd. I asked my fellow that, what stent was used. He says, Prof, I don't know what stent was used. And we don't know the name of the stent, so we call up the cath lab where the procedure was done. They find out the records and they tell us the name of the stent that they had used for the ostium of the LED. I had never heard the name of a stent, but this was a domestic DES, a hybrid DES, where they had put, so we put AI in the cath lab. I asked my fellow, okay, you put the name of the stent and let's see what ChatGPT tells us. So the stent was a domestic DES, which was a hybrid stent, which had closed cell design in the first two struts and open cell design downwards. So our wire into the circumflex had actually gone through a closed cell of the hybrid stent. The stent was actually not so thick. It was a hybrid stent, closed proximal cells, a cobalt chromium stent, only 65 microns, but it was not yielding at all. So, okay, I said, okay, so it's the problem is just the closed cell. I had never encountered a closed cell design in my own humble practice. So we thought, okay, maybe we do a repot in the left main with a very high pressure balloon. Maybe it will modify the stent struts a little bit. And after that, we'll take an OPN balloon to open up the closed cell design of the stent. So we take a 4.5 high pressure balloon, do a pot, and then take a OPN at 45 atmospheres, nothing. So even at OPN at 45 atmospheres does nothing to the circumflex ostium. So now we are left with very few options. I think we are not left with any option. So it's an undilatable stent strut, no calcium, and a closed cell design. He's a young male, 45, who has a patent LED stent with a dominant circumflex. So should we think about CABG at this point of time? I don't think our surgeons will give an arterial graft to this circumflex, and he's quite symptomatic with non-STEMI. So can we do something? I think the only option left was to cut this stent strut with a rotablator. I was trained at Singapore, my prof is also here, and we used to cut the stents not too frequently, but we had cut 2 stents when I was a fellow 10 years ago. And I thought maybe we can cut the stent struts into the circumflex. If they succeed, we may help this patient because we can't send this patient for CABG with a patent LED stent. So we exchanged the wire to a rota wire and over a microcatheter and took a 1.5 millimeter burr with the aim of cutting the stent struts from the left main into the circumflex. So this was a 1.5 millimeter rotablator burr at 180,000 RPM. I know that it's quite dangerous to cut the stent, especially into an angulated side branch like the circumflex. But we were very gentle, just keeping the rotablator because it's a front cutting device at the mouth of the stent. And we hope that this will eventually cut the stent. So we were very patient. It was almost 3 to 4 minutes of burring time. And finally, the 1.5 millimeter burr crossed into the circumflex. And here we can see that the burr is just kept at the mouth of the stent. It slowly makes its way, and then it finally crosses the stent. I'll just let it play, and then you see the cone of the rotablator has actually crossed the closed cells, and it has actually made some way into the circumflex. And then we successfully ablate the stent struts into the circumflex at 200,000 RPM, and we do 5 runs of this. And after this, we repeat imaging to see whether we have done anything to the stent struts or not. And surprisingly, there were no more stent struts left. So as you can see, this is the circumflex wire coming in from 4 o'clock, and we don't see any stent struts in front of the circumflex after doing the rotablator. The slide is not moving. Maybe the rotablator ablated the screen, is it? Can you play the presentation, please? Yeah. So this is the circumflex wire coming in, and this is the before rotablator. I'm sorry, this is. Yeah, so we see there is no stent struts in front of the circumflex after doing rotablation. This is the pre-run on the left side, and you see the post-run on the right side, that we see there are no more stent struts in front of the circumflex after successful ablation. So rotablator has made a space and has taken away the stent struts. And after that, our 3x12 NC balloon opens very easily at 12 atmospheres, so we are able to dilate the circumflex ostium. And then we achieve a very good dilatation at the ostium of the circumflex. And at this point, you can have a debate whether we should put a DEB, since the pre-dilatation results acceptable, or we should convert it into a culotte. I thought we'll convert it into a culotte, since we'll have more room for doing a POT in the left main, and also to have a proper result rather than using a DCB in such an angulated side branch, which is also very large. So we did a culotte from left main ostium to the circumflex using a 3.5 22 millimeter stent. And we did a POT with a 4.5 balloon and a final kissing balloon with 4 and 3.5 millimeter balloons in LED and circumflex. And this is the IVUS after doing the circumflex culotte into the left main. We see a very short neocarina, and then we have the wire entering into the left main. We had acceptable area in the circumflex of 8.5 millimeter square, and a very acceptable area in the LED of about 11.5 with the left main MSA of 14 mm square. So these were the final angiographic results in the caudal and the cranial projections. So this was the pre on the left side, and this was the final on the right side, and we have a very patent first OM. The patient has actually done very well at 6 months follow-up. So we had two problems in this patient. One, as Dr. Remo said, problem of ostial stenting, and the second was hybrid stent design. I think there is a problem of ostial stenting because of various reasons. This is what we published last year of modified POT. When we use a small size stent in the ostium of the LED, size to the distal LED or mid LED, and we start post-dilatation with a balloon from distal to proximal, the stent actually expands because the proximal it is malapposed, and the proximal 1 or 2 struts come in front of the circumflex. And that is why sometimes when we nail the ostium, it actually comes in front of the circumflex. This is, if we reverse this modification, if we reverse this post-dilatation sequence, that we first dilate the ostium of the LED and then go down, maybe we don't elongate the stent. However, this is only one of the mechanisms where the stent can move. This is more apparent in left main, where we suppose use a 3.5 millimeter stent in the LED, and then we use a 4.5 or 5 millimeter balloon to do post-dilatation with a traditional manner, which is proposed from carina to back. As we see, as the balloon is coming back, the stents keep on elongating because the cells open up and the stents actually elongate. Whereas if you reverse this sequence and you start the POT from the proximal most segment of the left main stent, you actually oppose the stent proximally first, and then you move to the carina. You actually do not elongate the stent. And this we published last year. Dr. Goran was actually the reviewer of the paper where we labeled it as modified POT, that we start from proximal and then go distal. So this may be one that could be done. Regarding the hybrid stent, so I took this stent from the stent company again, and took the stent to the bench. I started dilating the stent on the bench wired from the first closed cell. I was never able to dilate it on the bench as well. And even the balloon, once it opened, it got stuck in the stent struts and it never came out. Thankfully, it did not happen in our patient, but it happened on the bench. And I had 4 stents with me, and I destroyed 4 stents that day, where I started to dilate the proximal most closed cell, and I was not able to do it. So eventually, I will just say that please don't nail the patient. Each stent is different. Jailed side branch by a closed cell design stent is a big problem. Closed cell stent struts are not designed to open with a balloon. Use imaging to understand the reason for a balloon undilatable lesion. Rotablation may ablate these stent struts as the last resort, but should be done with extreme caution. We should always avoid ostial stenting and leave adequate room for POT, because we also know that some of the new stents have reinforced connectors in the first few cells, so we should try that they are never in front of the side branch, because they might be difficult to open. And you can, in the end, I'll say that you can almost never nail the ostium, but in tendency to do so, you can almost always nail the patient. Thank you so much.
Yes, you have only 6 seconds to discuss this. So, congratulations. You're very well, illustrated cases with all the options. I don't have any question because it's so clear. And if there are other questions from the
maybe just one short comment or question about DCB. Who would use would you use DCB? And because given the fact that no much disease was observed on the IVUS in the proximal circ, but large vessel, but perhaps DCB would do its work as well. Yeah.
Yeah, just because we had there were so many stent struts lying there, which would be just hanging around the ostia. We thought probably it's better to cover them with a stent and rather a DCB, but there was not much disease on the IVUS on the circumflex ostium, so a DCB might have worked. But because it was a large vessel, so we decided we'll actually cover the left main and do a proper POT so that if he comes back later, it would be easier to treat. So, but DCB might have worked, as you say.
Okay. Thank you so much.
Yeah, the other one comment I have is the rotablator technique was very good. 1.25 burr is not a good idea. It gets trapped. Go 1.5 to at least 1.75. And what it does, like in underexpanded stents, it actually creates heat. So you want to create as much heat as you can to really melt and break the stent struts. So go in higher speed. Not less than 160. You don't want to go low speed here. You want to go high speed, create and bigger burr, and create as much heat as you can to achieve what you did. So that was an amazing case.
But don't push too much. Yeah. Not to
just keep it there. It will go itself.
Not to wedge the burr. Okay.
Yeah.
Sorry, we have to go. We have no time. We have to go on to the next speaker. So now we have a DK string culotte. As a revamping the old kit, and the case will be presented by Dr. Richa Sharma. Please.
A very good afternoon to the House. So, Dr. Himanshu, he has already set the stage for telling us whether to nail the ostium or not. And this is kind of a similar case wherein we had a patient. So this was a 57-year-old gentleman who presented to us with the history of chest pain since 3 to 4 hours, and troponins were positive. So patient had a history of coronary artery disease. He had a stent implanted to his LAD in October 2023. We didn't have those records. It was done outside somewhere, and his echo was done immediately. He was having an ejection fraction of 30% with an anterior wall hypokinesia. So we did the angiogram of the patient, and this was the angiogram which showed that it was a left main bifurcation lesion, Medina class 111. There was some haziness at the circumflex ostia. The ostia of the LAD was critically diseased with TIMI 2 flow, and the proximal to mid part of the stent was patent. The distal part of the circumflex was also somewhat diseased. So now we thought that we need to do imaging in this case so as to find out the cause for development of this disease at the left main bifurcation as to what is happening. And probably on the angiogram itself, we can see that there was some stent struts hanging back into the left main. That is probably the previous operator might have tried to nail the ostia in this case as well. but the stent was pulled back, maybe because of the pot, as discussed by Dr. Himanshu. So we wired both the LED and circumflex, and in the second image, we can very well see the disease criticality into the osteas of both left main and into LED and LCX. We wired both the branches. We did the this was the pullback done from the left main to circumflex, and we can see that the LED stent struts was hanging into the left main. There was disease at the POC. The distal left main was also diseased, and thrombus was formed into the ostial part of the circumflex. In the third image, we can see that there was some thrombus into the ostia of the circumflex. The LED stent struts was lying there, and also, with the imaging, we could detect that our LED wire was through the distal stent struts. And when we took a pullback from LM to LED, we could see the circumflex wire, and it had to go through the most distal cells of the stent. So this was the pullback from the LM to LED. Here we could see that distal LM MSA was 5.24 millimeter square. Ostial LED MSA was 3.4 millimeter square with some thrombus overlying there, and a heterogeneous ISR was into the LED. And the LCX wire was through the stent struts, and so we were very clear that we can go ahead with the Culotte pattern, Culotte stenting in this case, and it was through the distal cell stent struts. So after this, the case was, after confirming that yes, our wire was through the distal cell, we just dilated the LCX lesion first with the 2012 balloon, and there was some difficulty sending the balloon through the cells, LED cell, stent cells. And eventually, this was pre-dilated. In the stent boost also, we confirmed that we were through the stent cell and not behind the stent cells. So we went on and pre-dilated the lesion with the 2O and 3O10 cutting balloon as well, because as shown in the previous case, we had to dilate the stent cells as well. So a normal NC or semi-compliant balloon would not do the job well. So after dilatation, the distal part of the circumflex was treated with the 314 DES, and then post-dilated with the 3.5 balloon. The same balloon was taken for pre-dilatation of the ostial part of the circumflex as well. And then we did our first kissing balloon inflation with a 3.5 mm NC in LED and similar 3.5 mm NC in circumflex at higher pressures. This was followed by a DES into LM to LED in a string culotte fashion. And the reason for implanting a DES in circumflex was because already there was a stent overlying the LCX ostia, and so and thrombus was forming over there because of the disturbed geometry of the left main bifurcation. We didn't want this to re-happen again, so we implanted a DES 4x23 in LM2 circumflex, followed by pot with a 4.5 mm balloon at 12 atmospheres. And thereafter, wire was recrossed in LED, and stent struts were dilated with a 2O semi-compliant balloon. There was some difficulty in crossing, but then it crossed. And thereafter, eventually, second kiss with 3.5 NC in LED and 410 NC in circumflex was done. And this was the result. I was very clear that I don't want to put any stent into the LED. We don't want to increase the metal layers. So since there was a critical disease into the LED ostia, the use of a DEB was considered perfect in this case. And thereafter, we just used a paclitaxel eluting balloon, a 3.5 into 20 mm in LED, followed by another kissing balloon inflation with 3.5 and 4O10 balloons in LED and LCX. The pot was done thereafter with 4.5 into 8 mm NC. And this was the final result. We did the pullbacks from LM to LCX, and we can see that the POC was not showing any hanging stent struts here, and so the chances of development of ISR would not be great this time, the next time. The patient coming back again to us with the disease would not be there. And similarly, this was a pullback from LM to LED. Again, the POC was clear. There were no stent struts. The LM stent was expanded well with the MSA of almost 14 to 16 millimeters square. The ostia of the LED was also 8 to 9 millimeters square, expanded well. And that was the final thing. This was the final result. So with the use of DEB and one stent, we could prevent multiple stent layers into the vessel. And thus, we come to the issue with bifurcation disease. We are discussing this, that ostial circumflex is the Achilles heel. EBC main trial also showed that despite whether we use a provisional stenting or a dedicated bifurcation stenting, the circumflex of the ostia is the most common site of development of the ISR lesions. And again, nailing the ostia, should we even nail the ostia of the LAD or the ostia of the circ, or do a crossover stenting and do a kissing balloon inflation and the final job? Plus, the use of DCB has really improved the geometry of and the flow turbulence of the flow dynamics of the vessel, and probably preventing the use of a metal layer into the vessel. That may prevent the development of instant restenosis or target lesion revascularization in the future. Something about DK Culotte strategy. So there are certain advantages of it. There has been a paper published in Eurointervention also that it improves the side branch ostium morphology, and there are less procedure times as compared to DK crush. Access, because of the access to side branch, it is better after first kissing balloon inflation, and even the second rewiring is easier in DK Culotte strategy. Also, at roof of polygon of confluence, DK Culotte has less malapposition as compared to DK crush and Culotte. Thank you.
Okay, so now we have a few minutes for discussion. Any comments from the panel, please?
I think you're very smart. You used one stent, and you got benefit from the overhanging stent with the left main. The old stent, you got much benefit from this maybe mistake by the other operator.
So that's the advantage of actually doing this as a string Culotte. Just go through the very distal cell stent strut, confirm it with imaging or stent boost that you are through. Once you are behind the stent cell strut and not through then the strategy will change. If you balloon it, it will crush the LED stent. So you have to be very confirmed about this thing, that you are through the.
Very smart, and you use just one stent to solve the problem. Yeah. Thank you.
Okay, any comments?
I want to comment. Frequently, when you nail the ostium of LED, is because you have frequently a dominant circ, which is bigger than the LED, and the LED is smaller compared to the circ. So frequently, because the LED is smaller, the operator put a 3/0 stent in the ostial LED instead of a 3/5 implanted at low pressure and then post-dilated. So if you have this protrusion and you go through the strut of the stent, you are unable to open completely because the stent will not open. Yes. So when you know this story, there is a 3/0 stent in the LED, you couldn't do Culotte. You should crash. You should crash the LED and then go with another stent. If you crash, you can have problem because sometimes you cannot go below the strut protruding in the circ. So there is a tip that you can do. If you are unable to go below the strut of the stent from LED protruding left main, you are unable to go outside the stent, you have to occlude the LED stent with the balloon. Okay. Go with the balloon, occlude, and then with the stiff wire, or you can go below and then crash. This is the tip that you have to learn. Yeah. When you have difficulty to convert to a crash, put another balloon, and then go with the other. This is just the tip.
This was an interesting tip, Remo. So I noticed that you have this combined approach with using a drug-eluting balloon.
Yes.
But then after the drug-eluting balloon, you post-dilate
with the same balloon, with the same DCB. So we can do that. We can put another.
So you're not afraid about the illusion of the.
The drug doesn't go back. Yeah. It has already been sent by the previous inflation. So you can just keep the balloon there and then another NC balloon into the side branch or probably the main branch here, and then do a kissing balloon inflation with the same. So I don't see any disadvantage with that.
Okay, good.
Thank you.
Okay, so if there is no more comments, thank you so much for the great case. And we move to the next presentation when we're gonna hear that 2 is better than 1 in rescue Culotte for left main bifurcation, and the case will be presented by Dr. Mattia Lunardi. Please.
Hello, nice to meet you. So thank you very much for your presentation, for your kind introduction. Sorry, I think they changed the order because I was late. So I don't know if I have to present now or later.
Do we have the proper presentation? Yeah, I think you
Okay,
go.
Thank you very much. So I'm Dr. Lunardi from Rome. I'm very pleased to present this, I think, interesting didactic case today. So we are talking about a 60-year-old man, actually with classical risk factors, and that presented to our hospital some years ago with chest pain, and he underwent a stress test that was positive and a normal echo. So the patient was referred to our cath lab, where we actually found a 3-vessel disease with a focal distal RCA lesion, a proximal circumflex lesion that actually goes a little bit up to the ostium, and then a mid-LAD lesion. So according to the SINTA score that was actually quite low, the patient was referred by our team to PCI, and the operator decided to go first for the right coronary PCI that was fixed in as the first lesion, and then to fix the circumflex, leaving the LAD lesion for a stage procedure. So after fixing the right coronary, the operators focus on the proximal circumflex, and according to the lesion, despite quite focal, the critical stenosis, he assessed the proximal circumflex as unhealthy. So he also, according to the bifurcation angle, and decided to go for an ostial circumflex stenting. So he started with a predilation with 225 and up to 3 millimeter non-compliant balloon, and then he went for stenting, trying to check the stent position with angiography from a spider view, and already from this angiography probably you can appreciate that the stent is not actually at the ostium but a little bit back into the polygon of confluence. The stent was a 3.0 by 23 millimeter stent. And actually, during the inflation from this position, the stent was displaced even more back into the left main. So you can appreciate that the marker actually was before the more proximal than the ostium of LAD. So anyway, the operator decided to postulate, and according to the angiographic result, he was happy about that. He didn't check in other way with the intravascular imaging and so on. And the patient came back in our cath lab for the stage procedure to the LAD after 5 days. But actually, because of some wiring difficulties to the LAD, we performed an intravascular imaging with OCT. And clearly you can see here the problem. The stent was completely protruding into the left main with some struts covering the entire ostium of the LAD, with major malapposition of the strut on the opposite side. So what to do in this case? We have a mid-LAD to be fixed, and also an ostium, or the ostial LAD to be fixed and to be reopened. The strategies could have been a lot, but at that time we decided to go for a rescue Culotte stenting, according also to the numbers of struts protruding into the left main. So first of all, we decided to check the wire position because we didn't want to destroy the stent or to crash the stent performing the first POT. So it's very important here to remind us that we have to check the wire, the main vessel, in this case the circumflex wire that is inside the stent and not beneath the stent in an abluminal position, in order to have the right position to perform our proximal optimization of the stent. After that, we performed the POT with a 4.0 and up to 4.5 millimeter balloon according to the dimension also measured at the OCT. And after that, I can now here starting the video. Anyway, we distally rewired the LAD. You can appreciate here the OCT after the first rewiring that wanted to ensure us that the rewiring of the LAD was the most distal as possible. In this case, you can appreciate the position of the wire just close to the carina with all the struts behind. Once having checked this position, so we proceeded with the pre-dilation of the LAD, covering also the mid-LAD segment that had to be fixed, with a 225 up to 3.5 balloon, and then we stented from the left main to mid-LAD with a 3.5 by 33 millimeter stent. After that, we performed a POT with a 4.5 millimeter balloon, and we performed the second rewiring of the circumflex. You can appreciate the pullback technique, of course, that is recommended by all the consensus to distally rewire also this branch. And after that, a kissing balloon with a 2.35 non-compliant balloon with a simultaneous deflation. So the final result after that, angiographically, was good, but in particular from an intravascular point of view, we can appreciate the LAD ostium that was completely fixed and the absence of neocarina thanks to the precise rewiring distal to the struts, the stent, and the well-opposed, of course, stent. The patient underwent an angiogram after 1 year that was okay, and after 7 years, the case is pretty old, he is doing well without symptoms. So my take-home message are that, first of all, when stenting, in particular the left main bifurcation, in a hostile position, both the LAD and the circumflex, we have to be aware about the possible consequences that we face, we may encounter if we are not precise or if we can't be precise. In this case, but in similar cases, the intravascular imaging is essential because, first of all, allowed us to diagnose the problem from the angiography. Yes, you can suppose there is there are some struts there, but you can very well appreciate how many of them. So according also to the quantity of the struts and their position, we can decide how to proceed to fix these complications. So you can plan your strategy. And during the procedure itself, OCT or intravascular imaging anyway, can help the operators guiding the procedures, checking the wire position, and so on. So in this case, the Culotte was a good strategy, I think, for this kind of complication. But we may also discuss about alternative strategies for protruding stents, such as in this case. Thank you very much.
Thank you so much for the great case. Maybe short comment. The first thing is that the relationship between marker and the stent is different in different balloons. For example, with Zions, the marker overlaps, the stent overlaps the marker, whereas most other balloons, catheters, there's a small gap. Yeah, so that's the first thing. Then the second thing, due to the fact that the vessel tapers, when you inflate too quickly, there will be some kind of prolapse, so the stent will tend to move proximally. Yeah? That would happen too when you deploy the stent. And then, of course, the solution is you must use imaging, because you don't know if you cross if the protrusion is the whole part of the stent, then you can use Culotte as you did. If there's just partial protrusion, the only thing to do is to crush the stent, as you mentioned before. Yeah?
Thank you.
Okay, so any comments?
And I think a third comment is the elongation, the potential elongation of the stent. In this case, if you are very precise, you may also have an elongation of the stent, so protruding the stent even if you are very, very good.
I want to underline that during the first procedure, when the operators, I don't know, another operator implanted the stent. So he did the good things. It was inject some contrast during balloon inflation, during stenting. You can appreciate if there is flow in the other branch, okay? And usually you can evaluate that there is a protrusion inside, so you can suspect that there is some protrusion. The second thing is the operator should always start from the proximal to distal. Otherwise, if it's protruding a little and then you start to post-dilate from distal to proximal, you protrude completely to the ostium you close completely. And this is the second message that was given. The other, you didn't do any stent enhancement, because if you do stent enhancement, and you inject some contrast at the end of the film, after 3 seconds, you can, in my system, I have the superimposition. So if you go in a correct projection, you can evaluate if there is flow and there is some strut protruding. Because it's very important to recognize immediately. We're lucky because the patient has to do another evaluation, but before have a stent thrombosis, it's better to evaluate even if you suspect you don't have the IVUS or imaging in the cath lab in that moment. It's night, it's acute MI, etc. But you have to plan to review the patient a few days later and to check if there is the suspicion. So inject during stent implantation, stent enhancement, you can prevent Another things that you can do is, if you have the suspicion and you don't do anything, take another wire and try to go in the side branch. If the wire doesn't go or there is some resistance, create a bend, okay, J, and try to go. With the J, it should go very freely. If it doesn't go very freely, it means that there is some obstructions and you have to take the suspicion that there is a protrusion.
Thank you.
The pitfalls in all these cases show that, ostial stenting has its issues. But even if you have to do it, like LED diagonal or this case, you really got to take time to image both limbs first, because you don't know really the disease distribution. So if you really want to do this, you really have to image both the limbs before you decide definitively to stent. I think it's very, very important to do that.
An additional observation. This case illustrates that nailing the ostium of the vessel, circ or LED, is not used because you have an ostial focal lesion that is, and the left main is involved. It's because you have a proximal lesion, which is easily treated, and then you want to go to the ostium because you want to go the more very close to the ostium. But these cases is more difficult than to do a culotte. If you do a culotte immediately, you don't have any problem of stent thrombosis. But sometimes the most risky lesion are the proximal lesion that extend a little to the ostium, and then you want to do to nail the ostium. There is another question.
Just about, I've never done it before, but I'm reading about it since my beginning in the interventional cardiology. What about the SCABO technique? SCABO technique.
The SABO technique?
Yeah.
Yes, I'll show you. No, it's not recommended.
Yeah,
It's suitable. It was developed in 2005 for angulated lesion like left main, and when there is a lot of motion during the. What means a lot of motion? When you have more than 2-3 millimeters to and through motion of the stent. When you have no motion, sometimes you can do with the. You put a wire, you have the marker wire, etc. But there is a lot of motion. The SABO technique was something that stopped the motion. So this is the only reason. But there are some problems, some complications. For example, because you have to open the stent, you deform the stent is a proximal strut. Second, if you make a mistake and you go too deep in the main vessel, this strut will be bented. And you will be, after deployment, unable to remove because it's bended and then jailed. And then you can deform the stent, lose the stent. So it's feasible, but there are alternatives. I'll show you in my last presentation. There are good alternatives now. You don't need anymore the SABO technique.
I think there are two modifications. One in SABO itself, it has recently, I think it is on the publications. They have said that you can use the second wire, a hydrophilic wire, just make a full bend of it right from going in, push the wire in the side branch intentionally, and then pull it. You will not be able to get into the main branch, the other branch ostia. That is one. And second, I think Dr. Scott Harding and his team has gone with the IVUS guided nailing of the ostia, which can be, it will require a little bit of more skill, but that should be one way. If you have to nail the ostia, we would be able to probably do it in a better way than just an angiographic.
Yeah, I've selected two modalities which are very effective, demonstrated, to nail the ostium. I show at the end of my presentation, if you want to nail.
Yeah. And people, go ahead.
I think in isolated ostial circumflex, in the era of DCB, we can use DCB only for isolated circumflex and bail out stenting if you have recoil or dissection. So what's your opinion about that?
Yeah, yes. Now it's an evaluation, but this is a good, because the circ is considered the side branch. So, but there are no result about these modalities. But we do, anecdotically, we do a DCB in osteal.
So, Remo, these are all very interesting. So let me play the devil's advocate here. So so what's the ideal technique, let's say, for you are dealing with a proximal LAD lesion, but you have a medium sized with an FFR, let's say, of 0.85 ostial LAD lesion, and which is the ideal technique on that time?
My presentation is step by step, so you will discover at the end.
Okay, so we need to wait for till the last presentation. Thank you so much. And we move to the next case, challenges in treating calcified left main bifurcation 001, of course, and the talk will be given by Dr. Sofia Papadopoulou. Please.
Thank you. So I'm Dr. Sofia Papadopoulou. I'm an interventional fellow at Royal Bournemouth Hospital in the UK. And today I'm presenting the challenges in treating a calcified left main stem 001 bifurcation. So our patient is 74 years old, and she comes in for an angiogram query proceed as an elective case. She has been experiencing angina in the last 6 months, and an echocardiogram has shown good left ventricular function. She had previous PCI to the right coronary artery in 2014, and at that point, moderate bystander disease in the LAD and mid-circumflex was documented. So this is here angiogram, patent stent in the right, possibly mild ISR. Moving on to the left system, and you can clearly see where the problem is the ostial circumflex. There is a lesion, and angiographically it appears heavily calcified. So she's very symptomatic. I'm going to treat this with stent. So what I have to think about now is how I want this to look at the end. I think it's been eloquently demonstrated by Dr. Gupta that nailing the ostium is clearly not an option. Two stent strategies is a good option, but do we want to leave all this metal behind in an elderly patient? Leaving no metal behind is an option, but where is the evidence for this? So we are really left with a provisional approach, left circ to left main, with an ostial, possibly a DCB in the LAD. I'm going to use imaging for this case, as is one Class A recommendation. The imaging tool of choice is OCT because it will more accurately describe the calcium. I gently predilate it with a balloon to facilitate OCT, and this is the first OCT run, which shows high calcium. It's eccentric. It's at the ostium of the circ, but also in the vicinity of the left main bifurcation. And the EL there was 1.3 square millimeters. I performed an OCT left main to LAD, and the ostium of the LAD has an MLA of 5 square millimeters, so not entirely normal. I have a Fujino score of 4, which means I'm going to use calcium modification tools, and I'm lucky enough to have all the tools on the shelf. In this case, I went with an IVL first approach. And the reason for this is that there's good enough evidence. There's a roller coaster study, there's an EmpowerCAD study that's shown encouraging first results. So we know there's similar efficacy with atherectomy tools, but the safety margin is better. So 120 pulses were delivered. Clear stent was used for optimal position of the electrodes to deliver the pulses. And then I went with a non-compliant balloon, a 3.0, a cutting balloon, and a 1-to-1 NC balloon. But there was still not adequate yield. So the next step was to perform another OCT run. And the MLA is still small. There's minimal fractures. And I felt that there wasn't enough lesion preparation to safely implant a stent. We're heading towards combination therapy, and laser is not indicated in this case, so it would be either rotor or orbital atherectomy. Because of the wire position, the wire bias, so the wire is clearly away from the lesion, I felt that the rotor would just go through without modifying the lesion, and decided to use orbital because of its elliptical nature. Apologies, I think it's moved forward. So I performed orbital atherectomy, exchanged to a Viper wire via a Caravel microcatheter. It was a 1.25 millimeter crown. To improve the safety, I glide assisted through the lesion and performed 10 runs, mostly retrogradely. An NC balloon, 1-to-1, fully expanded later. And OCT confirmed adequate lesion preparation. So we've got fractures of the calcium, and we've got a dissection. So at this point, the decision is to stick with the original destination strategy, which is a provisional approach, and implanted a Zion's drug-eluting stent 3.5 from the circumflex back to the left main, followed by a pot with a non-compliant balloon. So that's the result. Is the case finished? Can I see a show of hands? Who would stop at this stage? No one? Everyone would recross? That's what we did. Would your opinion change if I said that there was a start time of 9:20 and we're already 2 hours into the case? No, still recrossing. So that's what we did. We rewired with the dual lumen microcatheter. That was also in order to ensure that the wire was not abluminal, but also to facilitate distal strut rewiring. Performed KBI with 2 non-compliant balloons, PCI to the LAD with an agent drug-coated balloon, and then finished off with a pot. The OCT in the left main showed an MSA of 13.75, and the circumflex was 9 square millimeters. So it's a good result. I'm sure you'll agree the final angiographic result is also good. So in summary, I presented a case of a calcified left main stem 001 bifurcation, which was OCT guided with a shock cut orbital combination therapy, provisional stenting circumflex to left main, followed by a sequence of pot, kissing balloon inflations, side branch paclitaxel coated balloon, and a pot. We know both from bench studies as well as in vitro models that the pot kiss pot sequence is better than the pot side pot sequence. And also the DCB comes in because of the results of the DCB BIF trial, which is quite encouraging. So reflecting of the case, I went away asking myself whether orbital first would have been sufficient or wouldn't have to use combination therapy. I have good evidence to use IVL first, but I'd like to hear what the panel thinks about this. Secondly, underline the importance of zero tolerance for stent under expansion and the importance of lesion preparation. And also, I'd like to leave it open for discussion, benefits of the DCB in large side branches. Do we need another RCT? Thank you.
So I answer your question. First, I would done the same strategy. So usually, because you want to have, don't compromise the LAD when you do preparation. Shockwave you have 2 wires. You don't have to remove the wire with rotablation or atherectomy, and so you have the access to both branches. So the first choice is in a large vessel when you want to, you have the access. You predilated, and then this first choice is shockwave. Sometimes shockwave is not enough, and then you have to do what you did. You did correctly. The second question was
about DCB in large bifurcations. Obviously, we've got the DCB BIF study which excluded.
Yes, it's. There is no penalty to use the DCB. If the cost of the balloon is not, it don't increase the budget, I think it can be used. There is no penalty. And the second question was another one.
I just, this was a statement, zero tolerance for stent under expansion.
In my presentation, this is the first slides. When you have ostial, LED ostial circ, remember that in the ostial lesion are fibrotic or calcific. So lesion preparation is very important, and a stent should be, otherwise there is the risk of stent under expansion, which is zero tolerance for me.
Yes, so, if you did, these are the eccentric nodular thick calcium. I usually do orbital in these scenarios. Even orbital is not enough.
You use it as first.
If you use orbital or shockwave, I think the combination in these kind of cases is very, very important, because I do orbital a lot in these scenarios. Balloon still doesn't fracture all those areas. So you really, and what you did very methodically is image afterwards to see the fractures, to make sure you've really prepped the lesion. And in general, if you do that, you end up doing combination. Either one first versus the other doesn't make a difference. But imaging and looking at the fractures is critical in this scenario. So it was great.
Compared with the rotablator, you did the retrograde.
That's right.
Yeah,
yes,
this is the advantage.
The
in this case, you have not the bias of the wire. You don't risk to have any problem, and sometimes you have trapping of the burr because
risk of perforation.
If you have orbital, in this case, this is better.
Maybe one more comment regarding DCB. You prepped the lesion so nicely, and the result was so good angiographically. So I would even try to treat the whole thing with just DCB without stent, because the result was really, really very good. So of course we don't have big data.
We did have a small dissection there, but it would still be, I guess, okay to treat with DCB. But we don't quite have the evidence for this yet. So it's being reluctant with a lack of
the evidence is coming.
But I agree with you. It's tempting.
We're gonna have soon. Yeah.
It's tempting.
Okay. Yeah, one more comment from the audience.
Yeah, I have a question regarding the kissing. What was the reason? Because apparently it has a good result in the angio. If you have a good result in the LAD in orthogonal views and you have OCT, you see good situation, large cell, no yielding, what is the reason to do kissing? Do you do it systematically or?
I mean, it's a large vessel, it's the LAD, so we wanted to open the stent stretch. We wanted to make sure that we had, Karina, I did check and nobody would stop at that point. So yes, we not quite routinely, but we very often recross keys, and in this case we finished with a DCP. MLA was 5 square millimeters, and the LAD wasn't, the Ostium wasn't entirely normal.
Okay, thank you so much.
You.
And now we move to the last part, to the last presentation. And the Remo will summarize, is going to summarize what we have discussed already, and proposes some tips and tricks how to avoid all this problems.
How to prevent nailing the patient when nailing the ostium in coronary bifurcation. Which is this one, okay. So technical consideration, as I told just 1 minute before, it should be recognized that ostial LAD and an ostial circ can be fibrotic and calcific, and this may confer a higher risk of stent under expansion. And the lesion preparation is therefore crucial prior to stenting. We have all these traditional balloons, scoring balloon, you have rotational, orbital, you have the OPN, and you have these are all the tips. So you should prepare the lesion first things. Then I want to present this study from the Park group in Korea, published 20 years ago in 2005. In the methods, if you read the paper, it's written stenting procedure. 2 different strategies were applied to the stenting procedure according to the presence of intermediate narrowing at the distal left main. If you read the paper, in case of intermediate narrowing at the distal left main was intentionally covered with the sirolic muscle stent, the crossover stenting group. Whereas in lesion with the normal left main, the drug-eluting stent was implanted at the LED ostium. They called ostial stenting. So 20 years ago, it was the distal left main. The difference in strategy was based on the narrowing, intermediate narrowing, and they defined intermediate narrowing a diameter stenosis more than 30% by angiography or more than 40% by IVUS to a cross-sectional area. So in the last 20 years, I did the same. I did crossover in the majority because there was, why in the majority? Because 5 years later, in 2010, IVUS was strongly encouraged. Oviedo presented this paper 15 years ago. He discovered that there is, where is plaque really located? The continuous involvement from ostial LED into left main is in 90% of the cases. You see 62%, 14 means 90%. And the circ 67. So theoretically, we should do a crossover in ostial LED or in ostial LED in 90% of the cases. This is the last meta-analysis I found comparing an ostial LED lesion, comparing crossover to ostial stenting. There are more than 1,580 in the crossover and 800 in the ostial stenting, all the study from 2010 to 2023. And the TLR was lower in the crossover in this meta-analysis. So ostial stenting had more TLR. And also stent thrombosis was lower in the crossover. So ostial stenting, if you do ostial stenting, you have more stent thrombosis. This is the plot, but you have here the numbers. TLR was 10% in the ostial, 0.03% versus 5%, double. And stent thrombosis was 4.3 versus 0.9. But in this meta-analysis just published, they did a subgroup analysis, significant association favoring crossover stenting in TLR and stent thrombosis was observed in the lower IVUS use, but not in the IVUS use subgroup. So the conclusion is use of IVUS in ostial LED stenting. In 90% you do crossover is recommended IVUS, but I say is highly recommended when you do ostial stenting because if you the conclusion, use of intravascular images is essential in ostial LED PCI, and higher use attenuates the difference in outcomes between the two techniques. So when you have an ostial LED and you want to do the focal stenting, ostial stenting is more important to check and to evaluate that the distal left main is less than 40% cross-sectional area. You can evaluate also by angio, etc. So this is the first message. Majority is crossover to prevent any problem, but if you do ostial stenting, because there are the inclusion criteria in your mind to do an ostial stenting, you should use more, is highly recommended imaging. Pro and cons of both. If you do prices, ostial stenting, the left main is not stented, the circ is not jailed. The contrary is the risk of this geographic miss and the stent stenosis or stent thrombosis. If you do the crossover, there is less risk of geographic miss, but is the contrary of the pro, you stent the left main, you jail the circ. So the operator is always with these two. But I want to go on and say when we usually nail the ostium, the LED ostium. This is the first case. This is a proximal LED, and he went to go to the proximal, to the ostium. This is not a real ostium. It's a proximal LED that extends to the ostium. So we went to nail. For the circuit, the same. There is, or there is a big intermediate diagonal branch. I want to do, and we want to be able to do a provisional from the intermediate to the LED. So we want to have the space and to nail the ostium of the LED. These are the two cases then when always I try to nail the ostium or LED. The circuit is the same. You have a proximal, as in the case before. You want to nail the ostium, or you have a big intermediate marginal branch, and then you want to nail the ostium to be able to do the provisional on the real circuit, because you do an inverted provisional. But there are the risk of excess protrusion from the ostial LED and the excess protrusion from the circ. This risk, how to avoid this risk? So, what is the recommended stenting strategy to nail the ostium of the circ? Because the circ is considered in the left main the side branch. So you have the circ ostial and the LED ostial lesion. There are two different groups. First group is the ostial circ. 28 years ago, they presented this technique. This is stent pullback deployment technique. It's still valid now. So you go in A, stent is positioned in the circ. You put a balloon, left main. Then you inflate your balloon, 6, 8. Now you can go to 2, 3, 4. Then in D, you pull against the inflated balloon, and you create a dent, and then you deploy your stent. This is the best technique to use, and I have always used this technique for ostial stenting because the angle in the left main is favorable for this technique. It's Rinfret, which is a famous CTO operator. He did also from Canada. In 2024, he presented this paper. And this is the same. It's balloon-assisted pullback deployment technique. This is no protrusion. It's the first part of this paper, which is about nano-crash, because the second part is to protrude a little and create a nano-crash before to stenting technique. So I use the nano-crash. For me, it's very simple to go because I use it routinely when I do to stent technique. So we'll go with the balloon and then create this. Not recommended. The shoulder technique, which is ostial US isolated Medina 001, you crash. You crash without putting a second stent. In C, you crash. Then you recross, and then you do a drug coating balloon in the main vessel. And in F, you see the final result show a nice stent sleeve. It's not recommended for circ because this paper was on side branch, is diagonal branch, obtuse marginal branch. But the problem of this stent, the clinical outcomes in table 4, non-fatal myocardial infarction in almost 10%, in 4 out of 40 patients. So the risk to have thrombosis is very high. So I do not recommend this. Not recommended the flower petal technique because you have in A, on the left place, you have to pull back a little this plastic covering of the stent, inflate the stent at 5-6 atmosphere, and then you have this opening of the strut of the stent. In C, you put a second wire in green, and in D, you put a balloon with the 2 markers loaded. Then you go, you inflate in the first panel on the left upper. You inflate your stent, then deflate your stent balloon, and inflate the main vessel balloon. You have to create this string, and this is an example. And this is in the bench. This is the result they present in 59. I do not recommend because in this case you have to modify the stent, and this is what is not. It's better not to do this if there are alternatives. LED protrusion, how to avoid this protrusion is different because the angle is straight from the left main. So. What is the recommended strategy to nail the ostium? Simple one. Marker wire technique, published this article in 2020. You have the precise stent, the LED Ostium uses the marker wire. In the second panel in the middle, you see the marker wire in the circ, which is very visible. You can apply this technique if there is not a lot of motion, 1 millimeter, maximum 2. If there is more than 3 millimeter, doesn't work. I have to admit that sometimes I do not use IVUS to imprecise also LED stenting. How can you do without IVUS? So you check the precision injecting during implantation. You see that there is the tail, the marker, probably there is no protrusion. Then you do stent enhancement, the first stent enhancement. I didn't do the superimposition of the two, that you can see there is some flow in the circ. Then you do the post-dilatation with a bigger balloon, proximal to distal, not to elongate the stent. And then you recheck with this is final result. You recheck with the stent enhancement, which is in my computer like this. So you have the stent and then the superimposition. You can see that the stent is not protruding. So this is enough to say, I will not check with the imaging, the result is good, the balloon, the post-dilatation balloon is okay. So if you are in the night and you don't have the availability of IVUS in that moment, maybe it's not required to follow, to check this patient with an imaging. You have already seen this one. It's published in Asia Intervention 2024. You can use the pullback deployment technique in the ostial left main, same. You position the stent, you inflate the balloon, the stent is pulled against the inflated balloon until a dent is seen, and then you deploy. As Maciej told you, not all the stents are the same. What I use, you have stent on marker, which is the sky point now, and the Orsiro mission. All the other in green are, the marker is proximal to the stent. So then you have the two connectors and the 3 connectors. So for an ostial lesion, I prefer the 3 connectors. So I use for ostial stenting, the Science or Orsiro mission. Then I have the Onyx, I have the Ultimaster, but they are 2 connectors, so they are good for bifurcation, but not for ostial lesion. And then finally, the 2 studies that show you the feasibility of ostial stenting. This is published in 2022, is the body balloon versus the body wire technique regarding the accuracy of stent placement during PCI. It's a randomized, prospective, multi-center study. It's a small study comparing the body balloon technique with the body wire technique. Body wire, I go immediately, you put a wire on the right, put the wire, and the wire will stabilize the stent. The wire is in the panel B on the right panel. And then you inflate your stent in the C, and you have a precise position. And here is this illustration, the body balloon. So the body balloon, in A, you see, the usual length of the balloon was, in this study, randomized, 15-20 millimeter. The size of the body balloon should be selected according to the reference diameter of the coronary segment, 50-60% of the reference. So if there is a 3.5, you take a 2.0 balloon, 15. You put your balloon in A, beside the stent. Then you can reuse the pre-dilatation balloon. It's very easy. It was admitted. So put the pre-dilatation balloon below the stent. You jail the balloon whenever possible to contain the cost burden. The proximal marker of the body balloon should be aligned to or proximal to the marker of the stent. The body balloon was first dilated at 3 atmospheres. Body balloon, you inflate, the stent is deflated. An angiogram was used to confirm the location. Then, proper adjustment, the stent balloon was inflated at nominal pressure, with the body balloon inflated, and then was deflated. Was eventually deflated and removing along with the body balloon was removed after. If there was a problem, because the body balloon is jailed, with wire difficulty, the body balloon can be dilated again at low pressure while keeping the stent balloon in place for post-dilatation. So this is how to perform the body balloon. And this is the result, 66 patients who had been identified with significant stent movement, 3 millimeter going through, at 5 hospitals, randomly assigned to body balloon or body wire. This is the endpoint, and the endpoint will reach 93%, 94% of success with the body balloon versus 39. So body wire is not useful. If you want to stop the stent movement, take a body balloon, can reuse the pre-dilatation balloon, inflate, low pressure, inflate the stent, and you have success. Secondary endpoint, contrast volume was lower with the body balloon technique, and the procedure time also. Coronary findings. Target vessel was LAD in 70%, an ostial LAD in 30%. So that's a bifurcation. Was a bifurcation lesion in 70%. So this is an ostial LAD, a study about ostial LAD stenting. It was successful in 90%. What they use? 6 French guiding catheter, 90%, B&W CO for the first wire, B&W and CO, dilated, post-dilated in 50%, and the POT in 20%. So it's, the population is ostial LAD stenting. All the limitations, you can go to read the paper about the limitations. And this is the new things. Who knows the OSFI stent? Someone knows the OSFI stent? So this is, I didn't know before this presentation, but this has been published in Korean Circulation 2025, a few months ago. This is the OSFIT. It's a sirolimus elutive stent. You have in the upper part the 18 to 5, and then below the OSFIT is called Janus DES delivery system. You have the OSFIT. In the picture below, you see the shape of the stent, because there is the balloon is longer 5 millimeter compared to the stent. So if you inflate the stent delivery system at 1.5 atmosphere, only the first part of the balloon will inflate. If you go to 9 atmosphere, you have full inflation. So step by step, you go with your system. You position your stent in B, and then ready for inflation. You inflate the balloon, the system at 1.5, then you don't push, you push the stent against the ostium, you stabilize everything, you check with the contrast in F, you deploy your stent, and you are perfectly ostial. You can download this from this paper, ostial LED. You see the balloon in the left main, the operator is pushing the balloon, and this is after delivery of the stent. And this is the IVUS demonstrating the position, perfect position at the ostium. It's distributed in 40 countries, this stent. The Janus is produced in Korea. In Europe is Germany, Italy, and Spain, Switzerland, not in other countries, America, Asia, Middle East. They use this for ostial circ also, and for ostial right in the paper. Not recommended. David published this 25 years ago. It was the partial pre-inflation. I do not recommend, because there is a risk that pre-inflation could result in lodging the stent within the stenosis, not necessarily at the optimal position, and also further risk of loss of stent. The Szabo technique, 2005, you have to modify the proximal part. It was designed for bifurcation with a 9 angle. They reduced the problem associated with stent movement, but we have other simple tips and tricks to stop the movement now. It's feasible, 97% in 41 patients in 2008, 2010, the registry. Szabo reduced stem malpositioning and incomplete scaffolding 0%. This is a recent paper, 2017, ostial LED positioning to projection. They did also CT, good result in the circ. It's feasible, sometimes you have good result, but stent dislodgement, this is a paper published 15 years ago. The stent did not stop in the left main bifurcation, then they had to retrieve the stent, first. Second is this paper by by a group of Beatrice, and Ormiston was the bench testing, published in 2012. This is, in this paper, despite seemingly excellent immediate angiographic result, one case of IVUS examination, which was performed in 4 patients, was reported in which significant stent protrusion into the proximal main was observed, and Ormiston in vitro bench confirmed a significant and asymmetric stent protrusion into the main branch with the last cell of the stent undergoing significant deformation. So in the last 10 years, I never done this technique. Thank you very much for you.
Thank you so much. We are just slightly above the time. Maybe just one more tip regarding the stent movement during implantation. What you can do very easily is just to inject some atropine, and when it's like pacing during the TAVI valve implantation. Yeah, so then the movement of the stent will be not big. Yeah.
Yeah, it is used in the cardiac surgery to increase a lot of. There are, you know. In a critical patient, to use this is to adenosine risk. You have some risk. It's better to use other alternatives.
And then another comment on this balloon inflation and a dent, and you pull back and you see the dent. Unfortunately, all the studies did not really do imaging, and you tend to miss the ostium a lot, and that goes against every single thing you do. So I think you have to be careful, and if you do that, you want to make sure that you've covered the ostium on imaging, because even if you inflate, you see the dent. As soon as you inflate the stent, it usually moves, and you'll miss the ostium. So you have to be very careful. But you always, as I said, imaging in those scenarios is always mandatory.
If you don't have the OSFIT, I think that the body balloon is the best thing. That it's easier. We are able to. We now do, in bifurcation. We put the balloon gel in the side branch. We are you have experience with this, so it's the same.
Yeah, one more comment from the audience.
I had a perforation after maybe too aggressively dilating a proximal circ in a 001 lesion, and had to place a covered stent there, and had the use of using the balloon-assisted T-stenting with the balloon in the LAD and the covered stent in the circ. But there you really don't want to cover the LAD with the covered stent, obviously.
So use the balloon-assisted because it was a covered stent. You want to be sure that not to protrude anything in the left main.
Right. I've had a bunch of 001 lesions where on the stent boost I was really not happy with how well I dilated the ostial circ, where I felt I had some recoil. And then what happens is you increase your aggressiveness to dilate that, and one day it doesn't work. Then you get a perforation there, and now I'm back to not being so aggressive.
A final tip that, my experience, I use a lot of 6 French. Can do 3-5 with the 6 French. And using the balloon assisted with the 6 French, you go in trouble. So every time I have a distal, I have an ostial LED, and because I use and I want to do a precise ostial LED or ostial stent, right. I change. I put the Terumo exchanger on the radial, and I use a 7 French. So I recommend the 7 French to make the things easier for ostial LED, ostial circ.
Okay, thank you so much. We're going to close this session because the next one is going to start in 5 minutes. So thank you so much.